Hello friends, welcome to AI Medical School. So in today's video, we are going to discuss case number 3, which are related to respiratory, the chronic cough. Let's start with history. A 19-year-old boy has a history of repeated chest infections. He had problems with a cough and sputum production in the first 2 years of life and was labeled as bronchitic. Over the next 14 years, he was often chesty and had spent 4-5 weeks a year away from school. Over the past 2 years, he has developed more problems and was admitted to the hospital on 3 occasions with cough and purulent sputum. On the first 2 occasions, Haemophilus influenza was grown on the culture of the sputum, and on the last occasion 2 months, previously Pseudomonas aeruginosa was isolated from the sputum at the time of admission to the hospital. He is still coughing up sputum. Although he has largely recovered from the infection, his mother is worried and asked for further sputum to be sent off. The report has come back from the microbiology laboratory, showing that there is a scanty growth of Pseudomonas on the culture of the sputum. There is no family history of any chest disease. Routine questioning shows that his appetite is reasonable, micturition is normal, and his bowels tend to be irregular. Now examination. On examination he is thin, weighing 48 kilograms and 1.6 meters, 5 feet 6 in, tall. The only finding in the chest is of a few inspiratory crackles over the upper zones of both lungs. Cardiovascular and abdominal examination is normal. Investigations. Here is the chest X-ray, so you can pause the video and investigate it. After that, there are questions. What does the X-ray show? What is the most likely diagnosis? What investigations should be performed? The answer is, the chest X-ray shows abnormal shadowing throughout both lungs, more marked in both upper lobes with some ring shadows, and tubular shadows representing thickened bronchial walls. These findings would be compatible with a diagnosis of bronchiectasis. The pulmonary arteries are prominent, suggesting a degree of pulmonary hypertension. The distribution is typical of that found in cystic fibrosis, where the changes are most evident in the upper lobes. Most other forms of bronchiectasis are more likely to occur in the lower lobes, where drainage by gravity is less effective. High-resolution computed tomography of the lungs is the best way to diagnose bronchiectasis and to define its extent and distribution. In younger and milder cases of cystic fibrosis, the predominant organisms in the sputum are Haemophilus influenzae and Staphylococcus aureus. Later, as more lung damage occurs, Pseudomonas aeruginosa is a common pathogen. Once present in the lungs in cystic fibrosis, it is difficult or impossible to remove it completely. Cystic fibrosis should always be considered when there is a story of repeated chest infections in a young person. Although it presents most often below the age of 20 years, diagnosis may be delayed until the 20s, 30s or even 40s in milder cases. Associated problems occur in the pancreas, malabsorption, diabetes, sinuses and liver. It has become evident that some patients are affected more mildly, especially those with the less common genetic variants. These milder cases may only be affected by the chest problems of cystic fibrosis and have little or no malabsorption from the pancreatic insufficiency. Differential diagnosis. The differential diagnosis in this young man would be other causes of diffuse bronchiectasis such as agamaglobulinemia or immotile-cilia. Respiratory function should be measured to see the degree of functional impairment. Bronchiectasis in the upper lobes may occur in tuberculosis or an allergic bronchopulmonary aspergillosis associated with asthma. The common diagnostic test for cystic fibrosis is to measure the electrolytes in the sweat, where there is an abnormally high concentration of sodium and chloride. At the age of 19 years, the sweat test may be less reliable. It is more specific if repeated after the administration of fludrocortisone. An alternative would be to have the potential difference across the nasal epithelium measured at a center with a special interest in cystic fibrosis. Cystic fibrosis has autosomal recessive inheritance with the commonest genetic abnormality F508 found in 85% of cases. The gene is responsible for the protein controlling chloride transport across the cell membrane. The commoner genetic abnormalities can be identified And the current battery of genetic tests identifies well over 95% of cases. However, the absence of F508 and other common abnormalities would not rule out cystic fibrosis related to the less common genetic variants. In later stages, lung transplantation can be considered. Since the identification of the genetic abnormality, trials of gene replacement therapy have begun. Key points are: milder forms of cystic fibrosis may present in adolescence and adulthood. Milder forms are often related to less common genetic abnormalities. A high-resolution CT scan is the best way to detect bronchiectasis and to define its extent. Thanks for watching, and if you haven't subscribed to the channel, so subscribe to it and like the video.